Good day, everyone. I'm Dr. Aurora Gloria Padilla from the Philippine Pediatric Society, Southern Tagalog Chapter. Let's join in the celebration of the World Prematurity Day, the 17th of November. This is one of the most important days of the year as we increase awareness of the challenges and burden of giving birth prematurely worldwide. In this year, the global theme of the World Prematurity Day is Zero Separation, Act Now, keeping parents and babies born too soon together. Let these parents feel that they are part of your medical team in caring and management of these newborns. And to improve maternal and neonatal outcome, particularly this COVID-19 pandemic, please perform the early essential newborn care or the unang yakap, kangaroo mother care or the KMC, breastfeeding, and only breast milk is given to these newborns, and rooming in for stable late premature babies, regardless of the maternal COVID-19 status, with strict implementation of infection prevention control measures. If the baby is separated from the mother, start collecting colostrum immediately within 6 hours after delivery by hand expression using a 1cc syringe without needle, then every 2 to 3 hours to establish and sustain lactation. If with feeding cues, continue to support them and teach them the value of correct breastfeeding position and good attachment. Teach the cross cradle and the underarm hold and the proper collection and storage of breast milk. The best food for these newborns is the mother's own milk, and the best place is the mother's chest. Now, let's hear from Dr. Chris Grageda as he would talk about the fragile beginnings.
Good day. I would like to thank Dr. George Maravillosa, who is the current chair of the Child Advocacy and Community Service Committee of PPS-Southern Tagalog Chapter under the subcommittee of Dr. Aurora Padilla, Mula Sanggol. And of course, under the good leaderships of our President, Dr. Elizabeth Palines and Dr. Lizette Pontanilla. I am tasked to give a lecture for this special topic for Prematurity Week entitled Fragile Beginnings. This is the outline of my talk. I will discuss about my objectives, what is the burden of the disease, by presenting the local and the global statistics, define specifically the prematurity and low birth weight, what are the evidence-based interventions, what are the global and national strategies, and the last part will be to show you 3 videos about prematurity, continuing KMC and breastfeeding during pandemic, and discussion about retinopathy of prematurity. My objectives are the following. Number 1, to discuss the current neonatal care status of the Philippines and its performance both globally and locally as to the morbidity and mortality. Number 2, to understand the causes and management of premature deliveries. And number 3, to present quickly the common and neonatal problems associated with prematurity. Now let's talk about the healthcare perspective on prematurity. Prematurity and low birth weight contributes a big burden of disease on the neonatal mortality, both on the local and the international setting. This is the reason why a lot of researches or evidence-based interventions are being done or made involving global and national strategies. This pie chart depicts the causes of deaths of those under 5 years old and the proportion by which they occur. The yellow slices are the causes of neonatal deaths, and this make up 47% of almost half of all deaths in children under 5. The leading causes of newborn deaths are preterm birth complications, followed by complications occurring during the labor and delivery, and lastly, infection. Now, what can you say about the leading causes of neonatal deaths? They are all preventable, meaning there are interventions that can be done to lessen the incidences of these conditions. How can we avoid the complications of prematurity? We should prevent babies from being born early. Interventions include management of maternal conditions that predispose women to delivering earlier than her expected date, control of premature labor, and if delivery is inevitable, then giving of antenatal steroids to reduce preterm babies' risk of developing respiratory distress syndrome and intraventricular hemorrhage, among others. These are the leading causes of neonatal deaths in the Philippines, and the top three causes are the same with those seen globally. Those two figures showed the global distribution of deaths among children under 5 years old in 2018 and 2017 respectively. Noted is the 47% deaths occurring in the neonatal period. These top causes of mortalities nearly coincide with that of causes of deaths happening in the Philippines. In the Philippines, part of the leading causes of infant mortality are those associated with prematurity such as respiratory distress syndrome. Advances in healthcare management have significantly decreased these numbers, and ongoing studies are being done to see the effect of the various management strategies. This table shows the distribution of preterm deliveries in selected regions of the country and also shows how prevalent it is. It is at around 8.3% in Metro Manila. Now, the prematurity rate for the year 2018 to 2020 is more or less or approximately 12%. Let's talk about prematurity and low birth weight in details. What is preterm birth? These are babies born alive before 37 weeks of pregnancy. They can be classified into three: late and moderate preterms, who are born between 32 to less than 37 weeks, very preterm from 28 to less than 32 weeks, and extremely preterm, or those premature babies born less than 28 weeks. Around 7.6 million children die before their fifth birthday, with increasing progress since 2000 related to the Millennium Development Goals annually. Over 40% of these deaths now occur in the first month of life, which is the neonatal period. Again, I would like to emphasize that preterm birth complications is the first leading cause of death for children under 5 years old. And around 1.1 million babies die directly from complications of preterm birth. How about low birth weight? World Health Organization defines the following: birth weight, which is the first weight of the newborn obtained after birth, preferably within the first hour of life or after the first breastfeed of a healthy, vigorous, normal newborn. Low birth weight is defined as the birth weight of less than 2,500 grams or less than 5 pounds and 8 ounces. Globally, the prevalence of low birth weights is around 15.5%, accounting for about 20 million low birth weight infants born every year. Preterm birth is the leading cause of death for children under 5 years old. 1 million of them died directly from complications due to preterm birth, as recorded in 2015. There is around 15 million babies born prematurely every year, and its number is continuously rising. Across 184 countries, the rate of prematurity ranges from 5 to 18%. In our country, it is actually at the average of 10%, depending on the institution. These top causes of mortalities are mostly, if not all, preventable because of the lack of quality care at birth and lack of skilled care and treatment immediately after birth. Again, there are interventions and practices that can directly address the causes of neonatal deaths, and 3/4 of these deaths can be prevented not with the use of high-tech machines or expensive medications, but just with the simple and cost-effective practices that can be performed even in lower level healthcare facilities. Take note that our country, the Philippines, is situated on the Western Pacific area. What can be done? The target of the global goals for sustainable development by the UN include good health and well-being. So in the same manner, the top two that is related to our topic is based on our SDG set by the UN, which are number two, to end hunger, achieve food security and improve nutrition and promote sustainable agriculture. And number three, ensure healthy lives and promote well-being for all ages. The past years, the Millennium Development Goals were focused on preventing preterm births. To date, adding to efforts worldwide to further reduce infant mortality, the guidance offers recommendations on interventions which can be provided to ensure the improvement in the outcomes for preterm births by anticipating and addressing systemic complications of preterm births is imperative. These are the books or references where all these strategies can be based. No? Very important and very familiar with us is the one on our right, which is the first embrace, which we also call the unang yakap. Again, our global targets by 2025 is to improve maternal, infant, and young child nutrition. The first 1,000 days refers to a child's life from the moment they are conceived until they have reached 2 years of age or 24 months. This is the time when their brain, body, and immune system grows and develops significantly. What are the strategic objectives set by our national government? Number one, strengthen and invest in the maternal and newborn care during labor, birth, and the first day and first week of life. Number two, improve the quality of maternal and newborn care. Number three, reach every woman and newborn to reduce inequities. Number four, harness the power of parents, families, and communities. And number five, count every newborn through measurement, program tracking, and accountability. Millennium Development Goals were designed to improve the well-being of people in third world countries, which started in year 2000. Eventually, these goals were enhanced to cover all the countries around the world, including first world countries, to make it as what we term now as Sustainable Development Goals. What I want to emphasize for MDGs that are related with our topic are the first MDG, which is to eradicate extreme poverty and hunger through reduction of the incidence of underweight, stunting, and wasting. The number 4 MDG, which aims to reduce child mortality by improving the under 5 mortality rate and infant mortality rate. And number 5 MDG, which has the purpose of improving maternal health through increase in availability of skilled birth attendants, increase in the prevalence rate of contraception use, which will both improve the maternal mortality ratio. These goals were now replaced with the 2 Sustainable Development Goals also related to our topic, namely the number 2, to end hunger, achieve food security, and improve nutrition and promote sustainable agriculture in the newborn period through encouragement of exclusive breastfeeding, lowering the incidence of low birth weight, underweight, and against stunting and wasting. And the number 3 Sustainable Development Goal, which aims also to ensure healthy lives and promote well-being for all ages. In return, will improve the maternal mortality ratio, the under 5 mortality rate, and the newborn mortality rate. What the government did to reduce the neonatal mortality and probably reach the Sustainable Development Goals are: number 1, we have this Philippine Child Survival Strategy. Second, the Maternal Newborn Child Health and Nutrition Strategy. Third, the Essential Newborn Care Protocol. Fourth, the DOH-WHO POGS CPG Intrapartum and Immediate Postpartum Care of 2011. And fifth, the National Objectives for Health. The past years, the Millennium Development Goals were focused on preventing preterm births. To date, adding to efforts worldwide to further reduce infant mortality, the guidance offer recommendations on interventions which can be provided to ensure improvement in the outcomes of preterm births by anticipating and addressing systemic complications of preterm births is imperative. Now, what can all we do? The MNCHN or the Manchan strategy was put forward in AO 2008-0029. This strategy guides the development, implementation, and monitoring or evaluation of various programs aimed at women, mothers, and children, with the ultimate goal of rapidly reducing maternal and neonatal mortality in the country. This goal is to be achieved through provision and use of integrated Manchan services, which will create the following results. Number one is that every pregnancy must be wanted, planned, and supported. Number two, that every pregnancy is adequately managed. Number three, that every delivery is facility-based and managed by skilled healthcare professional. And number four, that every mothers and newborns must receive a good postpartum and postnatal care. Let me give you one trivia. Which do you think among these countries holds the record of the lightest baby to have ever survived? Is it Japan, Canada, Singapore, or USA? The answer is Singapore. Kwek Yuswan was born last June 9, 2020 with only a weight of 212 grams in National University Hospital in Singapore. She was born about 4 months earlier and the doctors had expected her weight to be at least 400 grams. However, it was 212 grams when she was delivered. She stayed in the hospital for around 13 months and was discharged only last July 9, 2021. And she is believed to be the world's tiniest baby to survive a premature birth. Prematurity really contributes a lot of burden and is a global concern. It is because probably of inequalities in the survival rates, like in developing countries, the survival rate is low as compared to the higher survival rate in first world countries. It is probably also due to the level of healthcare services that is available and the quality care before, during, and after pregnancy are all crucial. What are the basic causes for prematurity? One is multiple pregnancies, infections, chronic conditions like diabetes, hypertension, elective preterm deliveries, like the ones being decided to be born earlier, we term as late preterm, who are being born by cesarean section. And of course, the last one is unknown. What are the strategies to prevent prematurity? Number one is to give antenatal care guidelines like counseling and healthy diet and optimal nutrition. Second, avoidance of tobacco and substance abuse. Third, regular fetal measurements. Fourth, having regular prenatal checkups of a minimum of 8 set by the WHO. And then identify and manage the risk factors and better access to contraceptives. And lastly, increasing the empowerment of these pregnant mothers. Now, this figure talks about the causes of prematurity. Neonates may be born preterm following spontaneous labor with intact membranes. This comprises 40 to 45%. Preterm premature rupture of membranes, around 25 to 30%. Labor induction or cesarean delivery for maternal or fetal indications, which comprises 30 to 35%. Again, this figure shows the causes of prematurity. It can be due to intrauterine stretch, like multiple gestation, polyhydramnios, uterine abnormality, endocrine problems, intrauterine bleeding like abruptio placenta, antepartum hemorrhage, intrauterine infection like the most common, which is chorioamnionitis, bacterial vaginosis, preterm prolonged rupture of membranes, the fetal causes like IUGR or congenital malformations, maternal medical conditions like preeclampsia, hypertension, chronic medical conditions or urinary tract infection, and something to do with the cervical weakness. For extreme premature babies like less than 28 weeks, deciding about the timing of preterm delivery is most difficult at the limit of viability, around 20 to 26 weeks of gestation, and should involve the following: obstetrician, neonatologist, and parents. Decision-making is helped by a detailed assessment of fetal well-being, including the assessment of amniotic fluid volume, fetal heart rate monitoring, Doppler studies, fetal growth gestation, predicted birth weight, and this should also be informed by knowledge of outcomes of these early gestational ages. The national and international data are available but will need to be modified according to the circumstances and institutions' survival rate. Delivery of high-risk infants should occur at a perinatal center to avoid subsequent transfer and separation of the infant and mother. Although much of the attention of neonatologists is focused on extremely preterm infants, attention has recently turned to outcomes of infants delivered as late preterms. These infants have an increased risk also of respiratory morbidity and increased length of stay in hospital compared with full-term infants born at more than 37 weeks. Although the neurodisability rate is highest in extremely preterm infants, rates are higher in these infants than those born at full-term babies. There has been a marked reduction in the number of infants delivered before 39 weeks gestation in the US following new guidelines. Although the incidence of neurodisability is highest in extremely preterm infants, meaning the smaller and the lightest or the tiniest the baby is, the higher the rate of neurodisability. Rates are higher in these infants than those born at full term. There has been a marked reduction in the number of infants delivered now before 39 weeks because of these new guidelines. What are the other factors associated with preterm birth? It can also be due to social, personal, and economic characteristics. Like there is an increasing trend of having teenager mothers and women who are giving birth for more than 35 years old. The black race is also a factor, and the women with low income or low socioeconomic status. Another is about pregnancy and medical conditions like prior preterm birth or history of preterm births, of course, presence of infection, and carrying more than one baby or multiple pregnancy. The last one is about behavioral, wherein there is increased risk of prematurity when there is usage of tobacco, substance abuse, or even stress. The common complications of prematurity are the following. Number one basic problem is about thermoregulation. They're prone to develop hypothermia. Most common problems related to breathing, like respiratory distress syndrome, and then they can be prone to develop chronic lung disease or what you also call as bronchopulmonary dysplasia. And of course, very common also with them is about feeding problems. There can also be high incidence of cerebral palsy, especially if there is periventricular leukomalacia, evidently seen in cranial ultrasound or cranial CT scan. There's an increased risk of intraventricular hemorrhage and post-hemorrhagic hydrocephalus. There's also an increased risk of periventricular white matter injury, which is correlated with the increased incidence of cerebral palsy. Of course, the more common one, like the apnea of prematurity, and the others are at risk to develop severe infections because of the prematurity of the immune system, the problems with the GI, like risk for developing necrotizing enterocolitis, and because of the exposure to oxygen or other factors related to the development of the retinopathy of prematurity. What are the management being done which are evidence-based? Number one is giving of antenatal steroids. Maternal corticosteroids administered before preterm birth reduces rates of respiratory distress syndrome by 44%. It has also a good effect in reducing intraventricular hemorrhage incidence by 46% and neonatal death by 31%. It is also associated with reduction in necrotizing enterocolitis, use of respiratory support, intensive care admission, and systemic infections in the first 48 hours of life. A single course of administered to mother at risk of preterm birth up to 35 weeks of gestation is very important. In the UK, it is also offered to women having an elective CS prior to 39 weeks gestation to reduce the risk of respiratory morbidity. What about preterm premature rupture of membranes? It can affect 2 to 3% of pregnancies. It is associated with 25 to 30% of preterm deliveries. It increases neonatal morbidity and mortality due to prematurity, infection, and probably pulmonary hypoplasia. Associated with ascending maternal infection from the lower genital tract, about one-third had positive amniotic fluid cultures. Antibiotics can reduce chorioamnionitis and neonatal infection. The decision to deliver or manage expectantly requires balancing of risk of intrauterine infection compared with neonatal risk for prematurity. If less than or equal to 34 weeks, corticosteroids are usually given. Before 34 weeks, delivery is usually indicated. How about tocolysis? It is used to suppress uterine contractions. There is no clear evidence that any can improve outcomes, but is widely used to try to suppress contractions to enable completion of course of antenatal corticosteroids or allow maternal transfer to a perinatal center. How about magnesium sulfate use? It is being offered to mothers shortly before preterm delivery at 24 to 32 weeks gestation to reduce the risk of cerebral palsy. Several trials have shown a 30 to 40% reduction in the incidence of CP rates. Other forms of management are concentrated on the thermal regulation. For those preterms who are being delivered less than 1,500 grams or less than 32 weeks, they can be placed in this kind of plastic wrap to improve or to support thermal regulation. Another one is when they're delivered, it is very vital to prioritize feeding support. No? Like the earlier you can feed them, the better for the baby's outcome. Another one being adopted is the kangaroo mother care. In all institutions, it is always part of the protocol to adopt kangaroo mother care for those babies or even preterms or especially low birth weight babies because it has provided a lot of good evidence for the improvement of the outcome. And of course, encouragement of breastfeeding, which is the ideal form of nutrition to improve the outcome also. No? And lastly, the use of safe oxygen. It's very important for us to use oxygen in a very controlled manner because the toxicity it can provide cannot be overemphasized. These are the approaches: prevention of preterm births, like regular preconception care packages, antenatal care packages, provide education to promote appropriate induction and cesarean, and policy support including smoking, cessation, and employment safeguards for pregnant women. Another one is management of preterm labor, like the ones mentioned, use of tocolytics, giving of antenatal corticosteroids, and treatment with antibiotics for the PROM. For the care of the premature baby, as mentioned again, adaptation of the essential and extra newborn care, especially feeding support, proper knowledge about neonatal resuscitation, adaptation of the kangaroo mother care, use of chlorhexidine for cord care, and management of premature babies with complications, especially respiratory distress syndrome and infection. And lastly, the use of comprehensive neonatal intensive care, which will provide a better management where capacity allows. Now, these are the famous people born too soon. Mr. Wade Van Niekerk, he was only 1 kilogram. He won the 2016 Olympic Games and winning the South Africa's first gold medal. He had the best record for the 400-meter event with only around 43.03 seconds, smashing the world's record at the same time. Then there's Miss Anna Pavlova, who was also born premature in 1885. She was a ballerina Her small size and stature likely a result of her being premature. She set her apart. She set herself apart from other ballerinas at the time. Another very famous, Mr. Albert Einstein, a physicist and Nobel Prize winner in 1921. He was born in 1879 in Germany. Her mother was repeatedly frightened that her infant's head was so large and oddly shaped, and his parents were also worried about his intellectual development as a child due to his initial language delay and his lack of fluency until the age of 9, though he was one of the top students in the elementary school and then progressed rapidly from there. So he became, of course, a well-known genius. Another one is Stevie Wonder. Stevie Wonder, if you don't know, was delivered 34 weeks of gestation in 1950. His becoming blind is actually a product or a consequence, a bad consequence of his retinopathy of prematurity. Then other famous people are Sir Isaac Newton, one of the world's famous and influential scientists. He was born in 1642. He only weighed 3 pounds at birth and was not expected to live beyond a few hours. Not only he did survive, but he also went on to describe the laws and gravity of motion. Then Sir Winston Churchill, although he wasn't due to be born until January of the following year, Sir Churchill was born in November 1874. Although he was born also premature, he went on to become the Prime Minister of the United Kingdom, a gifted military leader, and a recipient of the Nobel Prize for Literature. The last part of my talk will be showing you videos about prematurity, guidelines in continuing KMC or kangaroo mother care, and breastfeeding during the COVID-19 pandemic, and some important points to be discussed about retinopathy of prematurity.
WHO recommends that all women should be supported to breastfeed. If COVID-19 is suspected or confirmed, these hygiene measures can help protect the baby. Washing your hands before breastfeeding, coughing or sneezing into a tissue and disposing of it immediately. Cleaning and disinfecting surfaces you have touched. Wearing a mask where possible. If a mask is not available, WHO still recommends breastfeeding, as benefits outweigh the potential risk of transmitting the virus.
These are my references. I also would like to acknowledge the health or residents from Hospital ng Makati, no? Dr. Jessa Mariano, and of course, Dr. Vanessa Senabre, my colleague, my also a neonatologist, who lent some of her slides about this topic. Also, my family, especially my twin kids, no, who were born also premature, but after 6 weeks. So they're now 6.5 years old now. So again, thank you for listening.